Michael joins us with 30 years of experience from industry before moving on to now his exploration into entrepreneurship, having retired as Chief Science Officer from a small company called Medtronic.
Thank you.
And so with that,
thank you, Steve.
Please welcome Michael to the stage.
Oh, thank you. Thank you very much. And I really do appreciate Steve. You know, I have a lot of respect and appreciation for Steve and all the work that he's done in helping to bring this entire area forward for people to start looking at all the opportunities. So I do want to share with you today, you know, it's a little bit about this industry and transformation. Steve asked me to talk about a little bit of history. I do think history is important because it helps us understand how we got to where we are today. But then tomorrow is basically what we decide and what we want to write. A few disclosures, as Steve said, you know, senior executive of Medtronic for a long time. The other two that I think are important are that I was an advocate for Medtronic for the Avicenna Alliance, and then I also have invested in this area personally. I think that this is a great opportunity and a lot of things to actually come of this in the future. So a little bit of a bias there because I do believe in it and I'm a firm supporter. I want to go with, you know, Patrick did a great job, I think, of explaining it from a large corporate perspective. This is actually from a patient advocate of how they describe what a virtual human twin is. The patient, the physical individual whose real-world health data feeds the twin, right? You have to have the data connection. You have to have a way to pull all of that information in, right? Something that organizes it, pulls it in from the medical data, the wearables that you might do, even from sensors in, say, a home, the rooms, the buildings that you go into. All this data has to be connected. Then you have to have the models. This is the in-silico part, a dynamic virtual model that simulates the biology, the disease, the treatment effects, all the outcomes that happen to that from an overall system perspective. Some type of interface. How do you interact with the twin? That can either be from the clinician interacting with them or even the person themselves. But you have to have a way to actually interact and get the information that you need. And of course, twin synchronization, continually updating so that you have the ability to mirror what the...
mirrors. I clearly heard mirrors.
Let me see thy face.
What wouldst thou know, my queen?
Mirror, mirror on the wall, who is the fairest one of all?
Famed is thy beauty, majesty. But hold, a lovely maid I see. Rags cannot hide her gentle grace. Alas, she is more fair than thee.
Alas,
Wow, that was scary. And that was for children. I am not that scary. Let me introduce myself. I am Michael. Sometimes I call myself the perfect Michael. I'm a model representation of Michael on multiple levels: genetic, subcellular, cellular, organic systems, multiomics, and complex multi-system interactions. I even look like him, but a bit younger and better. I'm going to work together with Michael to inspire you and spark your creative thoughts to look beyond the apparent, believing that nothing is impossible. So I will take over on this side and actually take a quick look at our history. I do think history is important for us to think about where we've come from so we understand how we've gotten to the place we are now, so it gives us an opportunity to look forward towards the future. Steve, who I have a lot of respect for and has done a great job of bringing this forward with some of the living heart. There's other people that have been working on this as well. In fact, the idea was first proposed in 1993 by Marco Visconti from Italy in Bologna, and actually was working on this with the Physiome project. It was basically a digital representation of the entire human physiology. From that, a lot of different things started happening, right? The virtual human physiology, the Avicenna Alliance, EDITH now, which is being driven in the European Union to actually be a model representation of a virtual digital twin. A lot of work, and we've come over the last 25 years or so with a lot of the technology computational capability that now is a foundation for what we can do using and going forward. It's not a technology issue anymore. It really is other things, and we'll talk about some of those for us to go forward. How do virtual human models advance innovations? I am a firm believer in the concept that the better you solve the problem, the greater value you create. If you understand the causative mechanistic effect of a condition, then you can design a promising solution. We as an industry are moving from the iterative product development model to predictive engineering, human factors design and development of products for reliability and scale. Virtual human models can advance innovations in many situations in which the physics are well established, the biological phenomenon is understood, and determination within human subjects unnecessarily puts many at increased risk of harm. These models can accelerate the cycle of innovation and provide a foundation for discovery and expansion of new opportunities. I will let the physical Michael give you an important example that he helped to drive at Medtronic. Thank you, Michael. Appreciate that. We did. At Medtronic, we had an opportunity to actually, how did we start to label our devices as MRI compatible? We know that MRI affects both the leads and the devices. It can actually damage the components within the actual active implantable device, and we know that the leads act as antennae. That's physics. We understand that. So how do we mitigate this? Part of this was using electrical and mechanical solutions to actually protect the things that are inside the active implantable. But for the leads, as an antenna, we can model those. Using modeling and simulation, we can understand also by measuring the amount of power it takes to actually create damage at the tip of the lead so that the pacing thresholds might change. Putting this stuff together, we could actually then start to make and build this model. We collected several different types of MRI scans from lots of varied physical and types of people so that we had a human anatomy boundaries. You can only be so tall or so short, so wide and so slender, so there's a human anatomy boundary. We also had the implanted lead boundaries. So what is the path, the shape of the lead, the placement that it goes? Well, of course, we're Medtronic. We have lots and lots of databases of how these leads are actually placed in the human body. So we could actually look for what the implanted lead boundaries would be. And then also then the MRI itself. The magnetic field energies that are associated with these, the magnetic gradients that are from these different pieces. And pulling this all together, we could actually build a model that we could then run these simulations to see how the lead placement, variability, the human anatomy, all of these things pulled in together. This is very interesting. So we actually did that. We ran hundreds of millions of simulations to predict how the device would perform with the risks and things associated with it. We created a safety margin around how much damage we expected from the antenna with the leads. We collaborated with Tina Morrison and her group at the FDA. They were very interested in us finding a way to actually use this modeling and simulation to help us actually understand even better than a clinical trial would provide us data, because we do understand the data, right? So this was a collaboration. We did do a patient study. So we did a 500-patient confirmatory, I would say, study that basically showed almost nothing. It just confirmed that in 500 patients, we didn't have any problems with the leads or with the device. But using this and the modeling, we were able to basically get our entire our ICDs, our pacemakers, and even our neurological products over a 5-year time period. We were able to get all of them approved for MRI compatibility, except for there were 3 leads that actually did not meet our safety margin requirement, and we did not label them for MRI compatibility. In fact, a couple of those we ended up taking off the market after all anyway. This avoided the need of doing extensive clinical trial work. It was going to require us to do tens of thousands of patients to actually demonstrate that little difference that you would get between someone that was damaged by an MRI and those that were not. It saved us probably 10+ years in time and over $2 billion in cost to do these studies. We improved the entire, like I said, pacemakers, ICDs, and neurological devices in 5 years for MRI compatibility. And we did that 2 years ahead of competition. So that actually made a big difference for us. We also, from a patient perspective, made sure that we didn't have the unnecessary risk of putting those patients at risk when there was no need for them to, because we understood and the model gave us a better data. So what about the future, right? Virtual human twins, what do they provide? Well, population health opportunities. We can look at it, it actually broadens our perspective. It'll allow better access, assessment, and optimization of broad populations. It can also help us monitor continually and support patients that have different types of chronic diseases. Chronic diseases are becoming something more aware of today, but that's because we actually live longer. We don't die from infectious diseases. We don't die from a heart attack. We live to have these chronic diseases. That provides an opportunity for us to do more continuous monitoring and help for a better patient outcome. And then narrowing it down to precision. So we could actually have a lifelong virtual twin that supports that personalized, precise, and predictive relational outcome to me, who I am. In order to do that, though, we have to have trust, confidence, and transparency. I mentioned at the beginning that it's not about actually having, the technology. The technology is not the issue anymore. It's really about how do we bring this out and have it to a broader application. And I think part of the theme of the conference was about trust and confidence. It really is about building that. And how do we do that? It's essential for public acceptance, right? The access and success of these virtual twin technologies and a lot of the different areas that we're doing, especially in healthcare, because it does deal with the patient and your interaction with them yourselves. When you get in on an airplane, very few people think about the digital twin of that jet engine. When you go to the doctor and you talk about your health, that brings a whole nother awareness for the person. We have to have good science. We have to have accurate and validated models to ensure quality, reliability, and effectiveness. We have to make sure that the information that we're putting in, the model that we have, is represented and that we're using it for the appropriate purpose. Extrapolating beyond a model oftentimes is just there for hypothesis generating and not for actual understanding and practice. We have to be very careful how we use these models so that we use them just like we do any model, whether that be preclinical or even randomized controlled trials, for the purpose in which they were actually built. And do this in an ethical, secure, and transparent application, right? We need to make sure that we build the public confidence, and we need to continue to do that in an ethical and appropriate way so that we can then continue with our effort. There won't be too many hiccups of things that go wrong. And think about like the self-driving cars, right? How many accidents, if you start too early, is it going to take for people to be more wary of it? But we know, because we're scientists, that once you get 66% of all the cars on the road as being automatic driving cars, you'll see almost zero fatalities from driving, right? But how do we get there? And part of that is building that confidence so we can actually do that. There is a framework. This is by Florence Hudson. Florence Hudson, she was with IBM, and now she actually works at Columbia. And there's a framework that's actually working in healthcare. This is also something that Tina Morrison at the FDA was looking at, and people in the healthcare area are starting to, and it's called TIPS framework. And you see the connection there with the big data hub. But it's basically about trust, identify, privacy, protection, safety, and security. It's not so much that if a hacker hacks in and gets my data, what are they going to do with my data, right? I'm an old white man. What's more important is they hack into it and they corrupt the data. So they either tell me that they're the physician and they make me do something that is a recommendation of my physician, or even worse yet, the information going to the clinician is corrupted, makes them make a wrong decision that then they tell me the wrong thing to do, right? So this corruption of information and data is becoming extremely important. How do we make sure that all of this information that's going back and forth, I mean, this file was huge for this presentation. That's just a presentation, a simple, easy presentation. Think about when we actually have our virtual twin and the amount of data computation that's going all over the place that can be intervened, corrupted, all of the things that are going on. So we have to make sure that we start from the beginning to build in that trust and confidence in what we're doing. We also have to look at the stakeholders that are at play, right? I talked today about the patient, but there's a lot of people who are playing in this field. right? We have to have all these people that cooperate and collaborate for us to move forward. Not only the patients and the patient advocates to say, you know, listen to me, engage with me, it's really about me, right? We talk to the clinicians oftentimes, we talk to the smart people at the universities, things like that, but what about the patient? I can tell you, because I had surgery for the first time in my life this year, it's a very different feeling when you are an executive at a medical device company, and I've been in hundreds and hundreds and hundreds of surgeries, and I've even actually done some on myself when I was younger. The difference when it's yourself that's going under the blade or when you're actually being put to sleep, your perspective changes of what does this mean, and am I interpreting this the correct way? I would hate to be my clinician. But, you know, I mean, it's a whole different ballgame of how you perceive it as the patient. Industry. Industry wants their return on investment. I get it, right? I understand that. How do you actually get something and make it advance? So we need to demonstrate that. We either get a faster regulatory approval time, like I mentioned with the MRI. We saved $2 billion in 10 years. That's huge. That's important, but we also got 2 years of exclusivity in the US with MRI-labeled compatibility and an uplift of price. I mean, that's gold. That's amazing, right? So how do you get that return on investment? Now that's as a corporate, right? My P&L says everything pre-market all fits under the R&D line. But what if I have a cost center and I'm sitting in research and they're asking me to do more work in my cost center to save that person over there in clinical their money in their cost center? That's a problem because I'm responsible for my cost center, right? So we have to also find a way that we actually, as leaders, allow the organization to change effectively so that they don't see it as more work, it's effective work that's preventing the quality issues downstream, the reliability, the field clinical actions, things that are going to happen afterwards. Again, that always affect the patient and the trust and confidence in what you're trying to do. Infrastructure, the hospital, I liked the presentation about, you know, how it all operates in the operating room and the infrastructure that's there. You cannot do things without the infrastructure in place. We take it for granted, but it's one of the most important foundations for us to be able to perform and do the things that we want to. Not only infrastructure in the clinical setting, but infrastructure in the computational setting as well. We have to have the power, the ability to transfer all that information, do it securely. How do we interface effectively? Is it really on your mobile? Is it going to be on the Google glasses? I don't know, but you have to find a way that you can interface with this as well. Government, they want to make sure that the data is valid, that FDA's purpose is to protect and promote public health. That's a noble mission. Sounds like the Hippocratic Oath, do no harm. Sounds like the Medtronic mission of using biomedical engineering to actually provide better lives for patients and longer lives, right? We have this shared goal. How do we help do that in a way that's effective for everyone? And then global, right? We are a global country, world now, and we're all interconnected, right? I live part of the time in the US and part of the time in Spain. I wouldn't want my basically digital twin to only work in the US. I want my digital twin to go with me everywhere I'm going. I want that digital twin to come to Spain with me when I'm in Spain, right? Insurance may not like that, but I do as a patient, right? Do you trust your twin? Kind of thought-provoking, right? Do you trust your twin? You know, the virtual Michael represents the biology, the physical characteristics of me. Again, maybe a little bit younger, a little bit better looking. But, you know, what does it lack? You know, it lacks several things. One is the emotional, experiential, humanistic personality of me, right? It has all the biology, it has all the modeling, it has all the data parts, but what about the me part that makes me the extrovert, that makes me, you know, very thought-provoking and always challenging every single assumption that can be out there, right? That's me. It also lacks some of the little quirks, the secrets that I don't tell people, the private thoughts that I have, right? A model can only be so good as what you give the information. Now, at some point, we may get to the point where if it is born with me from birth, as a true twin would be, and goes through my life, it may learn and have that lived experience that I have. But until that happens, it doesn't have that lived experience as a patient, right? It doesn't know that maybe I smoked when I was a teenager, right? It doesn't know that when I was in college, I did something maybe I wasn't supposed to, right? I'm not going to tell the digital twin that, right? I don't tell my parents that. Why would I tell my digital twin that? So that's then not a real representation of me. There's bits and pieces that are missing that still make me me. Right? So how does that actually work? Do you really trust your digital twin? It's that lived experience of the real Michael that matters, right? Not the beautiful, wonderful person that you see, but the real person, me. And in order for us to have that model there that actually is going to help interact with us, we need to make sure we have a real representation. And that also means trust for me in my digital twin. I might tell my digital twin those secrets that I had in college that I wouldn't tell my parents if I really trusted that they were trusting me, right? Wanted me, only between us, right? So how do we start to build that trust?
Finally, I'm back. I hope that you trust me because I want to travel alongside you for your entire life, helping in a way to be a manifestation of your own consciousness, a trusted confidant, and sometimes an action hero. So let's revisit that first introduction, from mirror, mirror on the wall, to how am I doing today? Am I prepared and ready to go? Let's take a look.
So let's take a look. Part of the fun of being in my position is going to the Consumer Electronics Show every year and actually seeing the technologies that are advancing. I'm convinced it's not a technology issue any longer. We have so many technologies. We have the computational power to do the things we want to do, right? It really is about understanding and building that trust and confidence of how do we make those decisions that we can then use that model to make important decisions that we need to for our lives, right? How many people are smokers or drinkers that go and have a heart attack, go into the hospital? What does their clinician say? Stop smoking. What do? They go home, they start smoking, right? It's because the physician is separate. It's like, you know, they nag, lose weight, do this, go exercise, right? Until it actually becomes my twin that then reflects onto me through the mirror that this is how I am, and I trust it, then your behaviors do change. We all use cell phones today, right? We do change behavior, but it has to take the right motivation. We have to trust it with the guts inside. Not data, it's about the gut inside, trusting, right? So I think we will get there. We have lots of opportunities, and I would say, you know, look beyond the apparent. Nothing is impossible. We just have to figure out how to get there. So with that,
Thank you.
and I'll take any questions.